without further ado, we'll hand over to Julie and Sam to take over. So over to you, Julie.
Hi everybody, I hope you're all okay. I'm a bit croaky today, so I do apologise now. My name's Julie Royal-Ever and I'm the team manager for the health facilitation team at LYPFT in Leeds. And I'm also joined today by my colleague, Dr. Sam Browning. Don't know if you want to introduce yourself, Sam.
I will do. Hi everyone. I think I know some of you. My name's Sam. I'm a GP, Leeds-based GP, clinical lead for learning disability for the CCG in Leeds, and also I'm lucky enough to be the GP for the learning disability health facilitation team, which means I work really closely with Julie. So really happy to be here today.
So welcome everybody. Today's talk, we're going to talk about strategies that we use within Leeds, within the health facilitation team, to try and improve the uptake and the quality of the annual health check for people with a learning disability. And obviously that then should lead to better outcomes for people. The strategies and resources that we use are published on our website, Get Checked Out Leeds. And all of the resources are free for anybody to use. We're happy to collaborate with any organisation to personalise the documents for their organisation. If you just contact us, and we can do that quite happily. The annual health check will only be offered by GP practices that have signed up to provide this with their CCG. So it might not be that some of your local GP practices have signed up, although I think all in Leeds have now signed up. So if you're a Leeds postcode, you should hopefully get the annual health check offered to the people that you work with. From slide 7 to slide 10, I'll be talking about the death of people with a learning disability. So if that's a difficult topic for anybody, please just feel free to dip out at that point, put me on mute, or turn off your presentation, the pictures of the presentation, and then maybe dip back in when I come back off topic. So I hope that's okay. So we just wanted to talk about, sometimes people don't know who the health check is for, and it's actually a check for anybody with a learning disability from the age of 14, which I think is another fact that people sometimes don't understand. And we have it from the age of 14 because if you are being cared for by a paediatrician, then at the age of 14, you're starting to think about, and your paediatrician and your team around you at that time will be starting to think about your transition onto adult services. What's good is to use those 4 or 5 years between 14 and 18 or 19, depending on when you transition to adult services. It's a really good time to get to know your GP and get your GP to know you. So by the time that you are discharged from CAMHS or paediatricians, you've got a really good working relationship with your GP and the practice understand you and your needs. And the GP has also got the support of the paediatrician who's still involved, but if he's got any questions he needs to ask about your specific condition, syndrome, etc., then he can get in touch with paediatrics and say, can you give me a bit of a hand with this? So please do encourage people, if you work with them, from the age of 14. The review is for a full health review that will hopefully highlight any health inequalities or any health issues early. By doing this, the person with the learning disability doesn't experience ill health for a long time before we actually recognise signs and symptoms of them being unwell. The annual health check is for people with a learning disability, and it's not for those who just have a diagnosis of something like ADHD, dyslexia, or other learning difficulties. Those two terms are very, very separate, very different. And it's also not for people who just have autism without the added diagnosis of a learning disability. There is actually an autism specific health check being developed in Newcastle just for people who have an autism diagnosis alone, but that's going to take a couple of years to filter out into general practice. It's not available right now. So the definition of a learning disability or intellectual disability, and I'm sure that I'm sort of teaching you all to suck eggs here, I'm sure you already know it, but it is usually or described as a significantly reduced ability to understand new or complex information and to learn new skills, and that's considered to be impaired intelligence. And it's also a reduced ability to cope independently, which is classed as impaired social functioning, which started before adulthood with a lasting effect on development. Sometimes you might find that people have got an IQ assessment, and that's a psychological assessment that looks at, it's an intelligence test, but it does look about the whole person. What different skills have they got? Add all of those skills up, and where does that leave them? And the result of an IQ test usually comes out as a score, as a number. Anything under 70 that was done on the Wechsler Adult Intelligence Scale, the WAIS, means that that person has a learning disability. 70 or above means that they don't have a learning disability. That's how we classify that. And it looks at the whole person. It's not just about, you know, how many A levels did they get, how many O levels did they get. It looks at all skills within that person's sort of persona and adds those up together. And remember, if you have a diagnosed learning disability, you should be coded with your GP practice on, and it should be coded as on Learning Disability Register 416075005. That's a code, those numbers are the codes that the GP practice will recognise. And we use the term on Learning Disability Register because some of our of the diagnostic labels that are given to people with a learning disability are not very clear that they are learning disabilities. So Kabuki makeup syndrome, you know, there's a cri de chat, then that's not, if you don't know that syndrome, you might not know whether that's a learning disability or not. So if you say on Learning Disability Register, it's like a tin of beans. When you open it, you know what's going to be inside the tin. You know that you have to give special dispensation to those people because they've got a learning disability. So terminology, words, diagnoses are all really difficult concepts sometimes. And the thing that we want to get people to understand is, you know, that learning difficulty and learning disability are not interchangeable terms. You or I might have a learning difficulty like dyslexia, but you wouldn't be expected to be added to the Learning Disability Register, would you? So that's what we want you to understand for our patients. And also to remember that learning disability is a diagnosis. It isn't a label. It is a diagnosis, and other examples of diagnoses are things like diabetes, epilepsy. So please do keep that in mind, that we're not labeling people. This is an actual diagnosis. Learning disability doesn't describe the person. We all know that the people that we work with are absolutely amazing people. They are skillful, they have got really full lives, they have brilliant experiences in their life, they are experts by experience, and they have lots of abilities. We are not defining them by the term learning disability. Learning disability can be classified as mild, moderate, severe or profound. When my own trust as a learning disability and mental health trust diagnose people, we tend not to give those classifications because for me, if you've got a learning disability, you should be entitled to a COVID vaccination earlier. You should be part of the flu vaccine uptake and offer for people. So we just class them as people with a learning disability. We don't want to exclude people because they've got a mild disability, because quite often they can be the most vulnerable people because they don't have big packages of care around them for support. Sorry, I'll just have a drink. And learning difficulty, like I said before, it's a condition that affects the way that a person learns, but it does not stop them learning and living independently. And they're the differences between learning difficulty and disability. So it's really important that we get that term right. So this, for in healthcare, this is what it looks like if you don't code people properly, if you don't give them the right label. We've got two GP practices here in this picture. So one is Dr. Ted's medical practice, absolutely brilliant practice, lovely, really nicely decorated and everything. And then the other one is Dr. Fred's practice. It's the health centre is Dr. Fred's. And that too is a beautiful surgery, really nice staff, lovely place. But at Dr. Ted's practice, nobody has a code of a learning disability. And then NICE or an NHS organisation, NHS England, say, bring out some guidance that relates to people with a learning disability. In Dr. Fred's practice, all the people with learning disability have the On Learning Disability Register code, and we'll call, just for visual purposes, they're the yellow pieces of paper on this poster. So if you were trying to contact all the people with a learning disability in a practice of, say, maybe 10,000 people, how quickly do you think you'd be able to do it if you were in Dr. Ted's practice compared to if you were in Dr. Fred's practice? And that's just a visual idea. For us as healthcare staff, we need to be able to identify people that need a certain level of support, and we need to do that quickly. And we need to be very, very clear about it, which is why I've gone on so much about the Learning Disability Code. If you see here, asthma might be blue, or diabetes might be blue, asthma might be a green code, but it would be very quick to pick those people out of that pile of 10,000 pieces of paper that represent our patients in a practice. So why is the annual health check so important? Well, the annual health check is really important, and it's a strategy that's been brought about after many, many reports that have said that people with a learning disability die younger than those of people who do not have a learning disability. And they're dying from things that are preventable and avoidable. People with a learning disability experience greater health inequalities, and it makes it harder for them to access healthcare fairly, unlike you or I. The Learning Disability Early Mortality Review leader count how many people with a learning disability die each year and assess why they died. And their reviews of deaths have shown that people with a learning disability die much, much younger. And these are some of the figures up to 2020. A male with a learning disability was dying on average 22 years younger than that of a gentleman without a learning disability. And for a learning disabled female, their average lifespan was 27 years shorter than that of a female in the community who didn't have a learning disability. So since 2017, Leader have been collecting all this information about the deaths of people in England and Wales. And they're collating information about the reasons why people die. And then from that, they're providing us with evidence so that we can action and change the way that we work. All of these deaths that have been reported have been highlighted as being unexpected, avoidable, preventable deaths of people with a learning disability. And the people who died, if they had a condition, say, that had an expectation that they would, have a shorter lifespan anyway, their lives, they wouldn't have died, they weren't expected to die, within the next 2 years of their life. So it was nothing related to their condition that made them susceptible to die early. It was something that was totally preventable, avoidable. We could have changed it if we'd have had better healthcare for people. And COVID has unfortunately increased those vulnerabilities for people with a learning disability. Also, from the 1st of January this year, Leader has now updated its name to Learning from Lives and Deaths programme. And from the 1st of January, you can also report the death of a person with a clinical diagnosis of autism. And because they're thought to have, and there is evidence to say that they also have really, really high mortality rates from preventable, avoidable health issues. So the leading causes of death, we've got respiratory disease. About 50% of LD deaths are related to respiratory disease. Things like aspiration pneumonia. So when people are eating and drinking, they're absorbing food and liquid into their lungs, which we shouldn't be doing, and they get infections, and then it ends up being, it's considered to be called aspiration pneumonia. Gastric cancers are twice as common in people with a learning disability than that of a person in the general population. Constipation, approximately 30% of the general population suffer with this. But if you look at a person with a learning disability, they are 70% times more likely to experience constipation. There is a case study of a gentleman called Richard Handley, who was 33, I believe, when he died. He had a condition that meant that he should have had extra care and support around keeping his bowels, you know, maintained in a positive manner, having more fluid intake, having a high fibre diet, getting more exercise to help him with his bowel movements. But that wasn't known by the staff team, and therefore they didn't act upon his condition. And despite him seeing many medical people, he actually died of aspiration pneumonia. When they did his autopsy, there was fecal matter in his windpipe and in his lungs. He surgically had 10 kilograms of fecal matter removed from his abdomen when he was unwell and in hospital. So the next time you go to the gym, please go to the weight section and see if you can lift a 10 kilogram weight. We have a bag, a rucksack with 5 bags of 2 kilograms sugar in it, and it is extremely heavy. And how people didn't recognise or didn't respond to what Richard must have looked like. His stomach was really distended to the point where he looked like he was pregnant. So, you know, for people not to recognise that and not to react appropriately and give him the right healthcare at that time is quite shocking. 7% of prisoners are thought to have a diagnosis of a learning disability that's probably gone unnoticed, and they've still managed to go through the criminal justice system and end up in prison, which of course then they are extremely vulnerable to being, you know, picked on whilst in prison and you know, not having a great time there and not being supported appropriately. 56% of people, sorry, with a learning disability have experienced some sort of hate crime from strangers because of their learning disability. And there's also a high level of mate crime where somebody befriends you, pretends to be your friend, and then starts, for example, taking money, taking your medication, bringing people round to your flat to do drugs or drinking or have parties, etc., etc. 40% of people with a learning disability potentially have a sight problem, and it's probably about the same level for hearing issues as well. But how many of our patients get to go to have their yearly or 2 yearly eye checks? You know, dental, because people don't have teeth, people are then not taken to the dentist, but you should be having a 2-year gum health check. Oral cancers are quite high in the learning disability population, and dental checks will help to identify that early and get them treated. And the COVID figures are shockingly, we're about approximately 6 times more likely to die of COVID if you have a learning disability. If you have Down syndrome as your diagnosis, then there's a percentage of 30 times more likely to die of COVID. Dr. Browning later on in the talk will talk about a way in which we're trying to support a reduction in the health inequality and communication of early warning signs of deterioration. So the proportion of COVID deaths of people with a learning disability compared to that of the general population. So the blue bar is people with a learning disability and the red bar is people without a learning disability. If you think about all the confusing and conflicting information that we have had over the last 18 months, I don't know about you, but sometimes I don't know if I should wear a mask, wash my hands, step 2 feet, 2 shopping trolleys away from people or what. The information's changed and it's been really difficult to keep up with that. So for our patients, they might not appreciate that they should be using hand gel or they should be wearing a mask. I think lots of patients have fallen foul of understanding how to keep themselves safe, and therefore there's probably a little bit of them being more vulnerable due to that, and also the fact that they don't communicate their illness, ill health, you know, when they first start feeling unwell. Research shows as well that not everybody with a learning disability is being prioritised for a vaccine. So when I was telling you before about the mild, moderate, severe, profound learning disability classification, some people felt that it was only people with a moderate learning disability that should be having their vaccine in cohort 6, whereas other people were giving everybody a vaccine in cohort 6, and we very much pushed for that in Leeds. we asked CCG to disregard the use of the classification of mild, moderate, severe, etc., and just say that anybody with a learning disability can have their vaccine. We didn't want people to be picked off the list for vaccination because they only had a mild learning disability. So inclusive communication for annual health checks, and I'm sure that if you're part of the learning disability community, you already have heard maybe about the Accessible Information Standard and the Equality Act and reasonable adjustments. And if you think about how our GPs write to us and how they communicate with us, sometimes it can be really difficult for people with a learning disability. Sometimes it's difficult for people who don't read and write because they've maybe, you know, struggled at school. And it could be difficult for people who don't speak English as well. So if I got this letter in a Chinese language that I didn't understand, I wouldn't turn up for the appointment. I wouldn't know what the appointment was for. I don't even know where the letters come from. And I might disregard that letter, but actually it might be a really important letter telling me to come for some cervical screening or breast screening, or if you're a man, AAA screening, diabetic eye retinopathy. So if we don't use easy read letters, how are our patients who do live independently, how are they supposed to understand what's coming through the door, and how are they supposed to engage well with healthcare? We develop in Leeds a lot of easy read documents, and there are lots of organisations up and down the country that do Change, do photo symbols, will develop different standards of and different types of easy read materials that people can use. And we've developed a whole suite of documentation that's supporting Leeds take up and promote the annual health check, but also promote people being able to engage with that as well. So they can give their opinion, they can give their view, give their understanding of their own health over to the doctor in a way that the doctor's going to be able to use it to make a formal and proper assessment of their health. So how can you tell somebody how you want them to communicate with you? So if you imagine practices have in the region of some of our practices have 25,000 patients on their books, how is the GP supposed to know how is the best way to contact you? In Leeds, we've got a system called the Reasonable Adjustment Alert document. Now, if you say reasonable adjustment to most people, they don't actually know what that means because they're fancy words, aren't they? They're not really. If you've got a learning disability or if you don't speak English, you might really struggle to understand what that means to you. So we've done a bit of a pro forma about what a reasonable adjustment might be. So we tell people that it could be that you want to use BSL, you know, you're a BSL signer and you want an interpreter that can support you with that. It could be that you want to tell the doctor, please only send me letters in easy read. It could be that you need somebody to come with you to help you engage with the appointment, like your mum or your carer. It's important to tell your GP and other NHS organisations so that we can get it right for you, so that we don't write to you in plain English and you can't understand it, so you don't turn up for the appointment. At the minute, we do not share this information between different organisations, but we are working to do that. So between ourselves, Leeds Community Healthcare, which is the community side, district nursing and things like that, and also between LTHT, which is Jimmy's, LGI, Seacroft, Wharfdale, Chapel Allerton. We're trying to get a way that all of our systems can talk to each other. So if a patient completes it at the general practice, we can then share it between all organisations rather than the patient or the carer having to establish this with every appointment that they go to. At the minute, I'd say make sure every appointment has a copy of what your reasonable adjustment needs are. But hopefully in the future, we'll stream that down and you'll be able to just tell one organisation. There are other things like I get really nervous and sitting in the waiting room might not be a good thing for me. So please let me sit in my car and give me a ring when it's my time to come in. especially people who have autism and a learning disability. We know that there are environmental challenges with sensory issues that might be really difficult in a really busy GP practice. So this would be a really good form to tell your GP, bring me in at a quiet time, or bring me in last thing on an afternoon when there's nobody about, everybody's gone home, there's just the doctor I'm going to see. And you know, it'll make for a better appointment. There's also space for you to say, look, these are not my reasonable adjustments, but this is my reasonable adjustment. And when you send that back to the health organisation, they should put it as an alert on their system. So when you then next look at that patient's notes, it comes up to say, please don't write to John, please send him an easy read letter, or please phone John, or please speak to John's mum because John's non-verbal. You can just establish those needs there. And that's on the website, like I say, it's free for you to use. It just helps you communicate your patient's needs, or your needs if you're a person with a learning disability. And anybody can actually use it because it is part of the Equality Act, which does relate to us all. We can all use this document. So annual health checks. In my experience over the last nearly 8 years now, Sam, we've been doing this. Feels like longer, but it's been a good experience, I must admit. But what we realised is when we were talking to carers, and that's, you know, parents at home or care staff in an organisation, we'd ask them, has the person had an annual health check, a learning disability annual health check? And they would say yes, they have. And then I'd ask them the specifics of that check. And they would say, oh, they had you know, a double appointment, 20-minute appointment with the nurse, and they had the heights, the weight and the blood done. Well, that's not an annual health check. So we've done a document to show you what the standards are, you know, what the GPs are actually contracted to do, because we want you to be better advocates when you go to appointments, to say, oh, actually, you know, we've not had a 30-minute appointment, we've only had 10 or 20 minutes, and this appointment should be a minimum of half an hour. You've not done a physical examination. Physical examination should be undertaken. None of us that I know of have got x-ray specs or x-ray eyeballs, and none of us can see if there is a lump or a bump growing under the skin. The only way you are going to do and identify that is if you do a full physical top to toe examination of that person and check for any lumps, bumps or anything else that shouldn't be there. You've got to be really hands-on with this, and that should be undertaken by somebody who is qualified to do that. So a doctor or an advanced nurse practitioner with the right qualifications to do that. The doctor should send you everything, the document about Get Checked Out checklist. This is a little booklet that will help you to communicate and understand what the appointment is about. So if once you get it a couple of weeks, you should get it a couple of weeks before your health check appointment. You can then sit down with your patient, or your patient can ask you to sit with them, and they can go through all of the different sections. The health check is quite comprehensive. It's top to toe, and it's, you know, it's a really in-depth thing. If somebody's going to the appointment and they don't know what they are going to, then that can be a bit of a shock when the doctor's asking about your boobs or your bum. You know, you might not expect that. We want our patients to be prepared and ready and organised and absolutely, you know, able to communicate effectively at that appointment. We don't want ineffective appointments. They should ask you about things like the influenza vaccine, which people should be having. We've got low uptake in the city, so please do encourage people to have the flu vaccine. There are lots of opportunities to have flu. It's free. Your GP can help with it. Sometimes we have some of the vaccination hubs are doing flu and COVID vaccinations in other areas, and that's worked out to be a really good strategy. And I've asked if Leeds can take that on as well. So, and also to remember that for a person who's scared of needles, who's what we call needle phobic, they can ask for a nasal vaccination when they go for their health check, or when it's, you know, if they're going to their GP for nasal vaccine, they can ask for the nasal spray, and they can be provided with that. The doctor should look at all of the national screening programs. There are 5. So there is diabetic eye retinopathy, bowel screening, cervical screening, breast screening, and there is also the AAA, so the aortic abdominal aneurysm or abdominal aortic aneurysm. I can't remember which way. I've had COVID, guys, and I'm really foggy at the minute. I do apologise. So it's AAA anyway, but that's for men over 65, and it's to check that they have no aneurysm risk there. At the end of the health check, the standard is that you should receive a health action plan. And the health action plan is to tell you that there is, you know, the blood pressure is not right, you need to take tablets and you need to come back in 3 months, or the person's got a lot of earwax, we need you to put the olive oil drops or spray in their ears, and we need you to come back and see the nurse in another 2 weeks. So for any issues that are identified within the check, they should be logged on the health action plan. You should receive a printed copy so that you as staff teams and carers and patients themselves, if they're able to support themselves to get better, know what their health issues are, and you can continue to work with them. So think about Richard Handley. The guy that died with 10 kilograms of fecal matter in his abdomen. He should have had, you know, about his diet, his exercise, his fluid intake. He should have been told to keep a bowel chart, to come and see us in 3 days if you've not been to the toilet, etc. There should have been a bit of a plan around supporting him with that there, and that would have helped the staff team to know what they needed to do. So the health action plan is very important. So I spoke quite briefly about the preparing for your annual health check. The Get Checked Out checklist, a little booklet. It doesn't have to be printed in colour. The GP can send it in black and white. A lot of our GPs don't even have a colour printer, or colour printing is quite a lot more expensive. So, you know, it's fine in black and white. It's not a problem. This is the booklet we use in Leeds to support you guys to understand and to get the communication right between all the parties that are involved. So the triangle of care, you need the patient, a carer and the professional to all be on the same page, and this document does that for you. It should be sent out to you a couple of weeks before your appointment, or if you wanted to print it out and start filling it in, and you know, if your GP is not willing to send it out to you, you can always print it out and send it in. You can actually fill it out online as well. We do have a PDF fillable version that you can use, so if you don't want to write in it, if you just want to keep updating an electronic version, you can do that. The booklet goes through all of the questions that you may be asked in the appointment. So you should answer the questions in the booklet before you go, so that you've got time to think about it. If the patient needs a little bit more help, we sometimes have a little hyperlink to more information in easy read. So for example, with cervical screening, we've got some information from Joe's Trust. We've got a really good video about cervical smears that's acted out by people with a learning disability. It's absolutely brilliant. And it really even, you know, it put me at ease when I'd read it, when I watched it. It was a really, really positive video. I think our patients would understand more about cervical smears if we offered them information like that. And then they can be part of the you know, the response as to whether they do want to take that up or not. It helps with your mental capacity questions that you might have to be doing, and the mental capacity assessments you might have to do, if you can evidence that you've shown them some good material that would help them to learn about these things. It also means that care teams are usually quite big. You might have 10, 15, 20 staff members, but there might be certain ones that have done certain appointments with people. So there might be one person that always goes to the dentist with the person, or always goes for their epilepsy review, and they would be the best person to fill that section out. It might be that a parent or carer still has some input into their young person's life, and they want to get on board and start working and help out with all the knowledge and wealth of evidence and knowledge and history that they have about that person. It gives you a chance to think and communicate when you get to the GP practice. And like I said, there are links in there that will help you to make decisions about whether you want certain things or not. The booklet doesn't leave any part of the body out, like I've said before. It does talk about boobs, balls and bums. It can be a bit embarrassing, especially, you know, if you're answering questions, but hopefully it gives you time to get over that embarrassment, and you can ask those questions in a, you know, you can do it in the privacy of a certain room, or you can let them read it first and then ask the person to come back if they've got any questions. It does all the men's health parts, it does all the female health parts as well. It reminds you about having your teeth checked, having your eyes checked, having your hearing checked is really important. A lot of our patients suffer with hearing loss, and we are working as a team with LTHT to look at a learning disability specific hearing clinic in Leeds going forward. It asks the questions that will show the doctor or the nurse that there are problems that they need to pinpoint when you go to that appointment. So rather than having to work everything out when you're in the appointment, and you know the appointment is a thorough one, it should be a thorough one, it should be a long one, but you know you want to pinpoint areas of ill health that might need to be flagged up and treated. And it actually talks about palliative care and end of life. For me, if we do not start to talk about these things in that setting, where do you then talk about them? When is it safe for a person to say, I'm worried because I've got dementia and I'll be coming to the end of my life and I've not done any planning? We do need to open up these. There shouldn't be taboo, you know, talking about the rude bits of your body or talking about end of life should not be taboo for healthcare appointments. It should be that you're confident and comfortable to open up to a GP, and a GP knows that you know about end of life, and you know you're part of that conversation. You should be part of that conversation. So like I said about the end of the health check, you need to look and make sure that you get your health action plan. If there are issues, it should say the health issue, the action that's needed. So that could be tablets, could be medication. It'll also tell you about who's going to do what. So it could be that as a support worker, you need to do the booking of their next appointment when they've finished the tablets or when they feel that they're ready to go back. And it also gives a review date, so nothing should be left for the, you know, and it's highlighted again in the next year. It should give a deadline and identify what that need is. Sam's going to talk to you now about Restore.
I think you deserve a break as well, Julie. I thought you were going to run out of steam for a minute there. You've done really well considering how poorly you've been. Hi, everyone. Yeah, I'm just going to talk to you a little bit about something we've developed in Leeds, and we're offering to all carers of people with learning disability. Julie's already talked about the horrible health inequalities and those statistics around premature deaths and preventable causes of death. And we, you know, things haven't really moved on massively over the years in Leeds or across the country, across the world. So we really need to start thinking about how we can tackle this. I think the health inequalities were more focused or more magnified by that horrible COVID pandemic that we're all going through and still going through. As Julie stated, there's lots of different reports. Depending on what you read, people with learning disability are 6 to 10 times more likely to die from COVID. And if you, like Julie said, if you have Down syndrome, up to 30 times more likely to die. A recent paper I read in some of the medical journals, even when you're admitted with COVID, if you have a learning disability, you're still 12 times more likely to die while you're admitted than any other at-risk group. You're also more likely to present to hospital needing more oxygen than any other at-risk group. And you're also less likely to receive invasive support, so the ITU, the intensive care support. So we really need to start looking at how we can tackle this and improve this inequality. One of the big problems with poorer outcomes for people who go to hospital when they have COVID is the fact that they get there a bit late, in that they've already got quite low levels of oxygen in their blood, and that's quite a significant indicator of a poorer outcome. Now, we know also that sometimes people with learning disability can't tell us, a lot of people with learning disability can't tell us what the problem is. And it's quite hard often to spot those subtle signs, those little hints, those changes in behaviours. Even if you know that person really well, it's sometimes difficult to put your finger on what's happening. And on top of that, even if you can put your finger on the fact that something's not quite right, it can be really difficult to get your message across to a healthcare professional. I know that, I've experienced it. I'm a parent carer of an adult with a learning disability. Even when I'm clinical, I have found it hard to get my message across. So I can imagine for carers who aren't clinically trained and have no medical experience, that is just a massive hurdle to get over. During COVID, there was it's still ongoing, a pulse oximetry at home scheme, which was for older people, not specifically people with learning disability. They were provided with the little gadgets that go on the end of your finger that measure the oxygen level in your blood. And the idea behind that was that if people's blood levels were getting low, they knew to take action and get to hospital quickly. So what we've tried to do in Leeds is combine a tool by which we can help non-clinically trained carers recognise deterioration in health in the people that are looking after, communicate it, and also use pulse oximetry. So we've used this Restore 2 Mini. Restore stands for recognising the early soft signs, so those subtle changes in people's behaviours and conditions, about taking observations, so writing those down, taking a blood oxygen level using a pulse oximeter, and then responding and escalating appropriately. So that's about taking action and then reporting your concerns to a healthcare professional, but also to give you a framework and a tool to help you be able to get your message across in a way that actually gets the outcome that you need for that person. Julie, if you just want to go on to the next slide. There we are. So we tried to put together an easy read version, an easy read explanation of what I've just said very long-windedly. What we really need to do is to make sure that you or the person you care for gets the right care at the right time in the right place. As I said just a few minutes ago, it can be really hard to know if someone's poorly. But we do know that if we can get people to hospital early on in that disease process, the outcomes are much more likely to be positive. We know that if people go to hospital and their oxygen levels are, say, 94%, or as compared to someone who goes to hospital whose oxygen levels are 93%, there is a 3-fold risk of death in between just 1% change. So it's really key to be able to measure something concrete like blood oxygen levels, as well as recognise those soft signs. So the training scheme that we've set up is about looking at simple tools, simple little reminder questions, using that Restore 2 Mini to train non-clinically trained people so that they can spot those early signs of a serious illness, whether it's COVID, pneumonia, sepsis. It doesn't matter what the underlying cause is, it's the spotting of the early signs that's important. So that's what Restore 2 Mini does. And then the addition of the pulse oximeter is just an easy tool. It's non-invasive, it's well tolerated, and it just gives you another string to your bow, if you like, so you can put across the argument that you know that that person is not well. And then one of the very important bits, and a lot of feedback we get from people who've had the training, is about the communication tool. How do you get that message across to the receptionist, the GP, the paramedic? How do you get them to understand how concerned you are? So part of the training involves something called SBARD, which is just a simple training tool. It's about describing the situation, the background, your assessment, your recommendations, and then your decision. It's a really helpful tool, and it actually reflects the way in which medical people tend to talk to each other. And when, as a medic, listening to someone who's had the training, I know they've had the training because I can hear the framework throughout what they're telling me, and it's really helpful as a clinician to help me decide what needs to be done for that person. Next slide, Julie. So yeah, I've probably already said a lot of what's on this slide. In summary then, it's just helping carers recognise those early signs of people becoming more unwell. It's knowing what that person is like when they're well, what's that person's best, if you like, and then noticing that something subtle has changed. It could be something as simple as they're a bit more clammy than usual, their behaviour's changed, they're usually quite placid and they're throwing things around, or they're just more withdrawn than usual. Or it could be that they've got a temperature or their colour changes. Lots and lots of real subtleties, and often they're very individual as well. There's not one size fits all with this at all. Then the other part is the communication tool that I touched on a few minutes ago. It's really difficult to get your message across, but if you have some training on how to explain your concerns, then you can get that message across and people will understand you on the other end of the phone. What we aim to do with this pilot scheme, we want to make sure that it becomes a standard service for all carers for people with learning disability. That's not just people who are professional carers, that's people in, yourselves maybe, who are in supported living services, care homes, but also family and unpaid carers who look after their relatives, friends and neighbours at home and have no training and very little support a lot of the time. Next one, Julie. So this is just a quick overview of what we offer in the scheme. We do a 1.5-hour training session. I'm hoping it's quite user-friendly. We have had some very good feedback from it. We ask people to fill out a pre and post training feedback survey so that we can continually tweak the presentation that we give and make sure it is fit for purpose, and we very much appreciate those. We make sure that everybody gets a free pulse oximeter for every service. If it's one person you look after, we give you one. If you've got 4, we give you one. So it's one between 4 essentially, depending on how many people you've got within your service. If you need more, you've only to tell us though. We've produced lots and lots of easy read guides. Admittedly, it's not always the person with a learning disability who's using the pulse oximeter, but I prefer easy read instructions, and I think most people do. So there's one on what is a pulse oximeter, how to use the pulse oximeter, and then what to do when you've got your measurements and your results and you've got your concerns building up. What do you do next? There's a recording chart and there's guidance on what steps to take and who to talk to at what time. Then we don't want to give people training and say, off you go, that's it, you'll never hear from us again. So we offer ongoing peer support. And we also make sure that all the GPs in the area in which you work, if you are having the training, are aware of the scheme. I do this repeatedly because GPs are inundated with information all the time. So we keep putting it in the GP bulletin to remind people, mainly so that when you are contacting a GP practice, that they know you've had the training and that they're receptive to what you need to tell them. And the other it's nice for me because I'm a bit of a nerd. I really like the fact that we've actually got a research project attached to this pilot scheme. The idea behind that is that if we can evidence base what we know will be good outcomes, because it can't not be, but we need to be able to give evidence to the policyholders and the people holding the purse strings, the fund holders, so that we can actually put funding in place and make sure this is a long-term offer for everybody in Leeds. I think that's probably the last bit for that, Julie, isn't it? Yeah. Happy to take questions afterwards when Julie's finished her next few slides.
Sorry, it's just decided not to. There we go. So I'll come back to you. If you've got somebody going to hospital, just to say that we, as organisations across the city, we realise that sometimes we're a little bit disjointed, but we're trying desperately to work more clearly together, so that the patient gets a better flow from one hospital to another. But if you are going to if you are taking somebody to hospital, or if you're a patient on this call and you are going to hospital, please make sure that you fill out your hospital passport. And again, this is available on our website. It's a document that just lets the people in the hospital know that you've got a learning disability and that you probably need a little bit more support when it comes to reasonable adjustments. We would also like you to fill out the reasonable adjustment alert and let the hospital know. And there is a specialist team called the Learning Disability and Autism team, which is headed up by Alison Conyers, my colleague here in the top left corner. It's really important that you let them know that you're going to hospital, because they will try and make sure that you have all your reasonable adjustments for your patient met. They'll flag the person on the system. So if they come in at the, midnight via A&E one time, that the hospital team will automatically know that that's a person with a learning disability, and we maybe need to do things a little bit differently to make sure that they're seen appropriately. So fill in the hospital passport, fill in the reasonable adjustment alert document, and tell the hospital team that you are coming, and they will make sure that the appointment is ready and right for you. And all of their contact details are here. They're on the poster. So just in summary, remember that we need you to log reasonable adjustments at your GP practice or any other NHS organisation that you visit. Make sure that you ask the GP about the person being coded with on learning disability register. That way the GP can pick them out easily. If there are any health interventions, it's really clear that this is a person that needs to be offered that health intervention. Think of the COVID, think of flu. Our people should be getting those vaccinations and those opportunities much earlier than anybody else. So please do make sure that they're coded accurately. They should have an annual health check every year. And the year for annual health checks is like a financial year. So it runs from April till the following March. Use the Get Checked Out checklist document to prepare and communicate well with your GP or any other health check appointment. So if you're, say, going to a colorectal surgeon for somebody because they've got a problem with their bowels, think about that section in the health check booklet and maybe fill that out. The health check booklet will identify that maybe you should bring a bowel chart, and then you're communicating in the right way with that health professional. You'll get the best out of the appointment. Do sign up for the Restore 2 mini training offer. It's really free, it's free and it's really useful. I personally have used it with my uncle who was really unwell with COVID, but he was saying that he was okay. And I made him take his oxygen saturation levels, and he actually needed to call an ambulance out because they were too low. But he didn't recognise that in himself. He doesn't have a learning disability, but he was just being a bit manly and didn't want to say that he was really, really poorly, which was really silly of him.
Julie, I think that's a really important point to make as well, because actually if you've got low oxygen levels, it affects your cognitive ability, even if you don't have a learning disability. So you can feel absolutely fine and you do not think you're breathless, you do not have symptoms, but actually your blood oxygen levels can be dangerously low. So it's not necessarily men being manly, it actually does affect your cognition. I've got a GP colleague who nearly ended up in a very sticky situation because she felt she was fine and she really wasn't. So imagine that in somebody with a learning disability, it's just compounded the issue completely. Yeah. Sorry if I interrupted.
No, that's fine. It's a good point. I'm actually thinking about it because, I mean, he's manly all the way through COVID, I have to say, but he peaked when it got to that bit. But also it affected his diabetes because he wasn't able to eat and drink as well. So actually, he also had low blood sugar at that time, which is another issue with cognitive impairment. It can impair your ability to understand your own, where you are with yourself and how well or how unwell you are. So it is, like I say, it's not just for our patients. I've used it for myself when I had COVID, and I also used it for my uncle. And it was really, it was really reassuring when I had COVID to think, oh, actually, I'm not as bad as I think I am. Just gonna crack on with it, Julie. But it can be really useful. And a GP doesn't do things like eyesight, teeth, checks properly. So do think about those being part of a person's, what you should be doing for a person. And if you are contracted by Leeds City Council, the Adult Social Care Services, you should be doing, this is all part of, Get Checked Out is part of your contract. So do make sure that you are taking people for these health checks. Don't just think, oh, they had it done last year, so they don't need it this year. None of us, I wouldn't class myself as a medic, unlike Sam, who is a GP. I don't have that knowledge and background, even as a nurse. I wouldn't say that I would be able to identify a tumour or some sort of mouth cancers or things like that. And don't take that on for people. Let the people do it who are qualified and able and commissioned to do that service for people with a learning disability. And just for the last slide, we wanted to open the floor up really and ask if there are any questions that people have. I've tried to respond to comments, and I know Jez has been helping us out with that in the chat, but is there anything that people want to know or want to ask? Just quickly, the other thing to say is, if you are having trouble accessing annual health checks with a GP practice, please do get in touch, and I'll try and help with that and help you to get the right offer for people going forward. Lou, you've got your hand up. Hi.
Thanks, Julie. Thanks, Sam. That's all been so brilliant. Can I ask at this point, are there reasons why people might not be coded or on the register?
I think from my point of view, it's sometimes, like I said in the presentation, it's really difficult to know whether somebody has got a learning disability or not. And some of the the things that people are coming up with now for diagnoses, micro deletion 13.2q of a gene, that doesn't say whether that's a learning disability or not. And we're not communicating that clearly. So if we know it is, it's not communicated clearly to the GP, and that means that they'll code them with the 13.2q deletion syndrome, but that doesn't mean that they automatically get on learning disability register code. So unless the GP recognises that condition as a learning disability, they won't get the 2 codes that mean it's on learning disability register.
And historically, it's been really, really complex as well. We've got the coding system within general practice does not communicate with coding systems, or the system itself doesn't communicate with any other system. You'd think the hospital and the GP would all be the same. It's not. And we've got some really strange, old-fashioned coding, really inappropriate coding. Some people who learning difficulties comes up time and time again. Even from paediatricians who've been looking after someone who's clearly got complex multiple impairments and a learning disability will write learning difficulties. So the GP who doesn't know that person writes learning difficulties and doesn't actually recognise that actually means learning disability for that person. So we're trying to change it. It's difficult. It's a bit of a minefield. We as a service offer GPs now that we will, with their permission, if they invite us to, go through their register, which means trawling through their register, trawling through patients' records, trying to pick out evidence of learning disability and making sure appropriate codes are on. It's much more difficult when people have a mild learning disability, because like Julie referred to earlier on in her talk, actually they don't often identify themselves and they're not in receipt of packages of care. They might not have gone to a specialist in inclusive learning college or anything like that. So it's not perfect, but we're working on it, and the reasons behind it being so rubbish are multifactorial.
Yeah, thank you. I was just wondering whether sometimes it was from an individual's preference or family or carer's preference as well, if that comes into it.
Yeah, I think so sometimes. I think you're right. And once or twice I've come across GPs who've said, well, that person doesn't want to be labelled, and that's why we're trying to get across that actually it's not a label, it's a diagnosis that allows us to make sure we are offering care in a reasonably adjusted manner and make sure you get everything you need. You know, people don't worry about being labelled as diabetic or labelled as being asthmatic. It's quite difficult when you speak to people with lived experience, families, patients themselves. There's a wide variety of opinions. Some people really don't like the term learning disability, and we have to understand that and accept that. But what we need to think about within services is that we need to focus on a diagnostic name, but what that person or the family wants to regard them as in everyday life is fine. You know, if they want to call themselves having a learning difficulty, that's absolutely fine by us. But for the purposes of healthcare and service provision, it needs to be that they have a learning disability diagnosis. Does that make sense?
There's, just to pick up as well, Sam, there's also the issue that education's labels that they use and diagnostics that they use, unfortunately, things like ADHD and behavioural challenges are actually listed as a learning disability. So you've got parents grow up saying that education's told me my son's got a learning disability, but when you look at their ability they clearly haven't. You know, they've just had some issues at school, say. So it is a massive minefield, Lou, and we've spent years trying to sort it out, but we're getting better, and we have got more buy-in now from NHS England, who provide a full report of all the, you know, strange and wonderful diagnostic labels that people have, and then it automatically, those codes automatically do say on Learning Disability Register now, but we're finding new codes all the time, so we're always on catch up as new genetic conditions are identified and are labelled as identified as having a, you know, part of that condition is a learning disability. As we find those out, we're trying to add them to that big list, that comprehensive list, so nobody should get left out eventually, but it will take a couple of years at least.
We are trying to move towards the more internationally accepted term of intellectual disability, so that we can stop with, because learning disability and learning difficulty feel so interchangeable and feel very easy to muddle up. So we're trying to move away from learning disability towards intellectual disability, purely for people with an impaired intellect. So learning disability as per the definition we have now, so that we don't get that problem with confusion arising. But it is very difficult to get everybody to accept that, even within health and medicine. And it is even more difficult if you start changing things for people with lived experience who might understand one diagnosis and then you say, oh, but we're going to change that to another name. That can be quite difficult to understand. So it's definitely a work in progress, but it's something we're very aware of and trying to make right.
Was just another question in the chat from Fahima. Her question was, is there an option on the new patient registration form for patients with learning disability to self-identify?
So we do ask that, because all GP practices will use their own new patient form, and we have asked as we've gone along over the years, and we'll pop it in the training and advise GPs to put a little box there to say, have you got a learning disability? So we are trying to get them to do that, but because there's no overall standard document that they need to use, that's a really difficult thing for us to implement, unfortunately. But we do ask that they do that.
I think it needs buy-in from NHS England before we can really effect change widely, and that's a challenge in itself, even for things like when we were trying to advocate for people having COVID vaccines in preference to other members of society. That took us weeks and weeks and weeks. Yeah, good point though.
Yeah.
I don't think there's any other questions in the chat. So, I don't know, does anyone else have any other questions for Sam and Julie?
Something else popped up in my head while Julie was on her last slide, thinking about things that GPs don't do, you know, your teeth, your vision. Yes, we can check for eye disease, but we're not that great at visual acuity and glasses and stuff like that. And hearing, yes, we can look in ears and we can see if they're full of wax, but particularly for people with Down syndrome, two yearly audiology is what we should be looking at. And that shouldn't just be for people with Down syndrome, anybody, I think, with learning disability, because if your hearing's down for any reason, that's only going to compound and complicate your communication needs. And it's fairly straightforward to put right as well. I've come across people doing annual health checks with people who are in their 40s who've never had a hearing test ever, and so some people who've never been able to communicate, and part of me thinks, well, is that because they've never had a hearing test, and had they had a hearing test in their 20s and had a hearing aid, would they have been able to communicate verbally? You just don't know, do you? It's not fair. It's another inequality.
Yeah.
Okay, if there's no more questions, then I just want to say a really big thank you to Julie and Sam for taking the time to talk today, especially Julie. It's obviously not feeling well, and to give such a great, plain, accessible explanation of annual health checks. It's brilliant, so thank you very much.
I do apologise, I know I'm foggy.
Oh, don't apologise, it was great, thank you very much. Thanks. Sam as well. So what we'll do is we'll collect the recording together and the resources and links and that, and send that round to everyone afterwards.
Yeah, and if anybody wants to, sorry to interrupt, Jez, I should have said, if anybody wants to get onto the Restore 2 Mini / pulse oximetry training, please get in touch with the team. The more the merrier. It'll really help. And if you know anyone else or any family carers who might like it, please do. We're pretty friendly, I think.
Okay, great. Thanks, Sam. Yeah, so thank you very much, everyone. So thanks for coming. Thanks for taking time out of your day to come to the session. And I look forward to seeing you at the next meeting.
Yes, Lou's got a hand up again.
Oh, sorry, Lou. Go.
It's okay. Sorry. Yeah, just a quick one really on the training, or maybe I can take it up outside the meeting, Sam. Is there an option to kind of do the training and then kind of do train the trainer sessions with staff teams?
I've done the train the trainer session, and I'd be very happy to take some sessions like that outside the yeah, I'm trying to think how I can't see why that wouldn't work, Lou. I think it would be really helpful, because it's quite difficult if we're just doing one session a week to get everybody to come onto a Zoom call, isn't it? So if we could start to look at training trainers within services who can then go on to train their teams. Yeah, I think, Julie, we should look at that really, shouldn't we? And see.
To be fair, Aspire have been our biggest, because we started working with you just to define the pilot scheme initially. So I don't see that would be a problem, really.
No, I think maybe if we just
get feedback from people about it, because in order for us to be able to justify rolling it out, Lou, we need to be able to have some evidence that it's working and it's good and it's right, and we're getting positives from it. So if we could get some more buy-in from Aspire to report back to us, then definitely we could definitely help to roll that back out to you as a full service.
Especially if we got feedback along those lines, Lou, saying, please, can we have some train the trainer? Then I can go back to the CCG and say, look, this is what people want. I'm in the process of writing an interim report now. So if you've got anyone who's had the training and who wants to send some feedback that I can use to back up my argument, then please just drop me an email.
That's great, because I think it might have been happening just as I started in post, so I wasn't involved in those early bits of implementation. So I'll get some feedback from it. Thank you so much.
Brilliant. Thanks, Lou.
Another hand popped up.
Yeah, Mandy's got a hand up as well.
Yeah, I just wanted to add to that, because we were meant to be getting together, weren't we? And unfortunately, we were in lockdown at the time to do a podcast with you both. And I think that would be a really good idea of being able to still do that. Obviously, I know we're going to book in another date with you both, but and then share that widely, you know, with all the organisations across Leeds, and that would be another way of getting it around a bit more easier.
Yeah, I can't, and I know I'm preaching to the converted really, but it would be just so amazing to get to every single carer across Leeds, because this will help. And I know people feel a bit nervous about coming to training, and especially if they see there's a doctor involved, you know, it feels a bit like it's a bit, you know, not for them, but it's not clinical. That's the whole point. It's about care. It's not about medicine. So if we can get everybody involved, everybody just feels better, because you feel more confident, and then we are going to get better outcomes for people with learning disability, without a doubt. I'm absolutely convinced of it.
We have already had some positive feedback about one person who the only thing that staff noticed is that her colour was off. So they did the measurements with the little machine, the pulse oximeter, and they realised that her heart was racing, and they got her to hospital, and she was quite unwell. But there was no other signs that she was poorly. So we've already had great feedback just from one service in the city, and there are hundreds of services. So we really, really want to get this implemented.
And lots of nice feedback from carers themselves, just feeling that they feel empowered to be able to do something. They feel like they've got some control, they've got an important role, rather than just being fobbed off, if you like, by medical professionals, which does happen, and still, you know, still is an issue.
Much less likely to happen if you say they've got SATs of 90, though.
Absolutely. Oh yeah, that'll make people sit up and take notice.
That's what makes the medic take notice. So.
They should take notice anyway, but that will definitely make them take notice.
It's a guarantee.
Yeah.
Say that. So
I'll link up with you as well, Mandy, on that, and Julie and Sam about getting that out through Forum Central to organisation and help develop that if you'd like me to do that as well.
That'd be amazing.
Yeah, that'd be great.
Okay, cool. I'm going to try and say goodbye again. Does anyone else have a question before I do that? If not, thanks everyone. Have a great day. Really good to see you all. And see you at the next meeting, which is the 23rd of March, 10 till 11:30. So take care. Yeah, nice to see your faces as
Thanks,
usual.
everyone.
Right,
Thank
cheers.
you so much.
Bye.